Respected National Office Bearers, Dr. Venkatagiri sir, President-elect, our state GC coordinators, Dr. Kanish Prabhu sir, our Tamil Nadu ISA past presidents, today's host ISA Tiruvarur, Secretary Dr. Ramachandran, Treasurer Dr. Lenin, and today's moderators Dr. Ramkumar Venkateshwaran sir, Dr. Mubarak, and speakers Dr. Pathsari sir, Dr. Akshay, senior members, delegates, postgraduates, and my dear colleagues. A very good morning to everyone. On behalf of ISA Tamil Nadu, we welcome you all for the 13th weekly webinar, and thanks everyone for the support and active participation. Before moving on to the agenda, we have 3 announcements. Shilpa, I wanted to share the slides. We are conducting the ISA Tamil Nadu Postgraduate Conclave on 18, 19, 20th December, this month, 18, 19, 20th. We have received overwhelming response both by means of registration as well as by abstracts. Shilpa, I wanted to share the slides.
Next one.
No, I'm having the slides.
Yeah. WhatsApp number. Yeah. Come.
Okay. So we have received more than 763 registrations and 203 abstracts. As for the announcement, we have stopped the abstract submission by yesterday evening 6 p.m. And we also received 30 credit points by Dr. MGR University for this Tamil Nadu ISA PG Conclave. So I request everyone to register and attend the session. My second announcement is for obtaining the Tamil Nadu Medical Council credit hours for this meeting. Please send your name. Please send your name alone to this WhatsApp number 7598360379. I repeat 7598360379. So please send your name alone to this number, and that too only by WhatsApp, not by text message. And about the third announcement, the chat box is meant only for typing the questions. Please do not type any other details in the chat box. It is very difficult for the moderators to find out the questions and go for the discussion. But for better discussion, please cooperate with us. Chat box meant only for typing the questions. With this, we'll move on to the today's agenda. I invite Dr. N.S. Ramachandran, Secretary ISA Tiruvarur, to deliver the welcome address. Over to Dr. Ramachandran, please.
Sir, unmute. Sir.
Ramachandran sir, please unmute.
Good morning, one and all. On behalf of the Tiruvarur ISA and ISA Tamil Nadu State Branch, I welcome Dr. Sudarshan and Dr. Prabhakaran and Dr. Edward Johnson, Academic Coordinator, and Dr. Prabhakar, and all the past presidents and all the delegates, and today's moderator, Dr. Ramkumar Venkateshwaran and Dr. Mubarak sir, for this wonderful webinar on 13th webinar of Tamil Nadu ISA. We are ISA throughout is a pioneer in starting this type of webinar by our president, Dr. Pathsari. He is regularly conducting Fridays, everybody knows, and every Friday he is taking classes for postgraduates and practicing anesthesiologists. And by this, I welcome you all, everybody for this 13th webinar of ISA Tamil Nadu. Thank you.
Thank you, Dr. Ramachandran. Now I welcome our most active ISA Tamil Nadu President, Dr. Sudarshan, for presidential address.
Good morning, everyone. Respected President-elect ISA National Dr. Venkatagiri, and President Thiruvarur branch, Dr. Ramchandran, Secretary Leo, and my dear President-elect of ISA Tamil Nadu, Dr. Kumar, Academic Coordinator Edward Johnson, Senior ISA National Past President Dr. Kameshwar Rao sir, who is joined here, and all the senior ISA National Past President and the State Past Presidents, and my dear colleagues, President and Secretaries of every city branch of Tamil Nadu, and all the invited guests from the other states. Very good morning to you, all of you. It is indeed a great pleasure that we are consistently performing this webinar series for the 13th week in succession. And all these were possible only because of the excellent support from all you members. I'm sure we will conclude our first turn of all branches meeting within this month. And we are also, as I said earlier, we have proposed to host a summit meeting at the end of it all, which will be in the month of January, and details of which will be shared to you shortly. And presently we have the task in hand. I think Kumar has already shared the details. The overwhelming response of the PG Conclave, it is primarily focusing on the postgraduates presenting papers and also the abstract submission. And it will be done on 3 days. And on the third day of the event, it will be purely, that is the coming Sunday, will be an abstract free paper for award papers. That is on Sunday. That will be for a 2-hour session. And we are also proposing to have, in addition to the paper presentation, award paper, we're also proposing to have PG's most wanted career guidance advice and career guidance discussion. What you could do after your post-graduation, what is the options to join in a Western country, in both in United Kingdom and I think Australia also. Our academic coordinator Edward will share those details. So those things are in the pipeline. So next Sunday also, do not miss. The postgraduates will be benefited what you could do after your post-graduations. We have 2 speakers from UK joining. What are all the avenues they could explore joining in United Kingdom training and further improve on your curriculum career. And I thank the moderators, Professor Ramkumar, one of the very, very senior postgraduate teacher from KMC Manipal. We've been known to him more than now 25 years now. And of course, Dr. Mubarak, my dear classmate during postgraduate time. And we spent a lot of good time. And they are all experienced teachers. And they are here to share their views on the subject. And I think it will be of immense benefit to all of you. And I thank Dr. Punuraj, the Medical Council observer, who's here today and who will be sort of one of the attraction of these meetings are primarily the credit points offered by the Medical Council also, along with the content of the academic matter. So with these small details, I thank all of you for joining consistently, and I hand it over back to Dr. Kumar. Thank you.
Thank you, sir. Once again, I request everyone in the chat box, please type only the questions. Please don't type any other details. Thanks for your cooperation in advance. This will move on to the today's academic program. For that, I invite our academically very active Tamil Nadu ISA Academic Coordinator, Dr. Edward Johnson, to proceed with the today's academic program. Over to Dr. Edward, sir.
Thank you, the President and Vice President. I welcome you all for the successful 13th CME of Tamil Nadu ISA, hosted by Thiruvarur ISA. I thank the overwhelming response to the PG Conclave, which is going to be conducted the 18th, 19th, 20th of December. And the highlight of the 20th event, that is Sunday program, is the for overseas career guidance for the postgraduates. 3 sitting examiners of the board examiners have accepted to guide our PGs in that day. So it is a great opportunity for our postgraduates. Please attend that and get the guidance. So coming to this today's academic event, today's topics are evolution of English and aesthetics and recent update by Professor S. Partha Sarathi. And the second topic is can see the larynx, cannot intubate. It's an interesting topic. I am waiting. So it is managing the crisis by Dr. Akshaya N. Shetty. I welcome these learned scholars to this ISA academic forum. Today we are blessed to have two legendary scholars, Professor Ramkumar Venkatesan and Professor Dr. K.K. Mubarak, as one of our chairpersons. So the Ramkumar Venkatesan sir is the former professor and head of anesthesiology of Kasturba Medical College, Manipal, and he is currently the chief editor of Airway Journal. We welcome you, sir. The other chairperson is well known among the postgraduates, Professor Dr. K.K. Mubarak. He is a professor and HOD anesthesiology since 2009. He worked at the Government Medical College, Kozhikode and Thrissur, and he is a PG examiner both for DPNB, D and MD for the last 12 years across the India. He is well known among our postgraduates. He is a past ISA secretary of Thrissur and Kozhikode. He has presented more than 20 publications in the index journals and presented papers in state and national ISA. He is the editor-in-chief of Indian Journal of Anesthesia and Analgesia, IJAA, and he has started Calicut Anesthesia Academic Program, CAAP, since 2012. With that short introduction, we will move into the main academic event. I invite Professor Ramkumar Venkatesan sir to introduce the speaker.
Thank you, Dr. Edward. Is the audio okay, Edward?
It's okay, sir.
Okay.
Yes, sir.
Thank you.
Okay.
Yeah. So, first of all, I must thank the office bearers of the Tamil Nadu ISA for inviting me to be a moderator on this very well-intentioned and necessary academic program in these days of COVID. I think spreading education is the best way we can keep our own knowledge going and keep our younger generation also updated. And I thank all the office bearers of not only the Tamil Nadu ISA, but also the National Forum who are present today for inviting me to the session. I also thank Dr. Ponuraj, who's our MCI observer. Thank you so much. And thank you also for awarding those points, which are very important for all webinars and academic programs. To go on to the first topic, which as Edward already said, is on the evolution of inhalational anesthetics and recent updates by none other than Professor Parthasarathy from the Mahatma Gandhi Medical College and Research Institute, Pondicherry. I was just looking at Dr. Parthasarathy's CV, and he's, I think to sum up in one sentence, he's a multifaceted, multi-talented professional who practices anesthesiology most of the time, but can also do many other things. He's got many other bows to his strings to his bow, so to say. And I realized that he is not only a very accomplished in various fields of medicine like acupuncture, diabetology, special PhD in physiology, research methodology, and so on and so forth, but also as a linguist. And he's a Tamil poet, and I have, of course, read some of his Tamil poetry with the translation that he has sent out on groups earlier. He's also Praveen in Hindi. Parthasarathy rubs shoulders only with big people, it appears, because he received the Praveen Award from none other than Indira Gandhi herself. And also, he got an award from APJ Abdul Kalam for being very active in obtaining the eye donation for transplants. So he's a multifaceted person. I've heard him speak before. He's a very dynamic speaker. In fact, I can call him a dynamite when he speaks. A very knowledgeable person and drives home his points very effectively. And so without wasting any more time, let us invite Dr. Parthasarathy for sharing his treatise on the evolution of inhalational anesthetics and bringing us up to the recent updates. Over to Dr. Parthasarathy.
What is that I should do after opening this whiteboard? Yeah.
You share your screen, Partha.
1 minute. I will open
Sir,
this.
you can.
Shilpa?
Yeah. Sir, you can see your, sir, keep your PPT open first. Then
I have opened it.
Okay, so in the Zoom share screen.
1 minute.
You did yesterday. You did
Yeah.
well.
When you click on the share screen, you will get a dialog box where you can see a thumbnail of your PPT.
Yes. Yes, coming. Wait. Started.
Yeah.
Yes.
Am I
Go
audible?
ahead. Yes.
Yes, clear.
Yes. I
Slide.
will just. I will.
Presentation mode, sir. Slideshow.
Yes, that I will. After this, I know.
And your voice is very loud. You can keep your mic little away. You're a very loud
I
person.
don't have mic. I'm just speaking some
Natural
30
voice.
centimeters away from the laptop.
Which is why I said he's a dynamite. Yeah.
So, first of all, I'd like to thank Dr. Ram Kumar Venkateswaran sir for this wonderful introduction about me, like dynamite. So that is why I'm very this thing about concentrating about my audio, because dynamite should not become like Botswana. So, so I'm very careful about this audio. And at the outset, I will also thank the office bearers of the Tamil Nadu ISA who has been consistently really working like to get this. I don't know whether these people are practicing or something like that, going on constantly. Edward Johnson and all, going constantly involved in PG academics. A wonderful work, sir. And I also thank the National ISA bearers. And let us start, sir. So this evolution of inhalation agents, and somebody has put a recent update. I don't know whether this recent update will be carried out by well knowledgeable moderators, our moderators. So it's basically a 19th century to 21st century transition. That's all. So whenever I talk anything on academics, I put a big salute to the man, the legendary teacher of 2 centuries, who knows gas man better than this inventor. So why this topic of ether to sevoflurane, or so-called revolution of anesthetics, have come? We are going in search of the Almighty or the ideal anesthetics. You know, there is a great saying, unless you know the past, you cannot make advances. Who has said this? Yes. Unless you know the past, you cannot make advances. So this is the past from 1846 here to 1990s or 2000. The ether to chloroform. You can see chloroform in around this 1846. You can see ethyl chloride in 1885, cyclopropene in 1929, halothane in 1953, and enflurane in 1980s, 73 actually, and chloron 1990s. What's an ideal anesthetic? Physical, a boiling point above ambient temperature. For example, a theater ambient temperature is 21 degrees or 23 degrees or 20 degrees. If the boiling point is 18, it will boil. So there is no use. The boiling point of the agent should be more than that. It should need a simple apparatus. It should be chemically stable, long shelf half-life. It should not corrode metals, plastics, etc. It should not be inflammable. This is an interesting sentence or word in English, no? When you say visible and invisible, they are opposite. When you say active and inactive, they are opposite. But when you say flammable and inflammable, they are synonyms. That is a big thing or a speciality about this word, flammable or inflammable. Cheap, this word doesn't like by Dr. Meenakshi Sundaram. He said cost effective is better. What is the pharmacodynamic ideal anesthetics? High potency, should be potent. That's what we are working for. It allows high FiO2. It should have a high therapeutic index. For example, sevoflurane action is 2% and it produces toxicity at 3.5%. There is no use. So analgesic, it should have, but preferable. What is this? Pharmacokinetic, low solubility, rapid onset and rapid offset, adjustable depth, minimal metabolism. Okay, now it should not get metabolized into hydroxy, adjust the liver, kill the kidney cells. All these things should not happen. Predictable in all age groups. So it should have minimal toxicity and minimal advantages. Nausea and vomiting, no. This is what I want to impress on, the cardiac arrhythmogenicity. It should not be sensitizing the heart to exogenous or endogenous catecholamines. No staff also problems. Certain terms need introduction before I start like. Now you see, saturated vapor pressure. Now the liquid is there in a closed box. It will start vapor. This is the vapor, okay? This vapor creates a pressure that is vapor pressure. Now, 3 molecules will go in and 3 molecules will come out. Then it means it is saturated vapor pressure. The number of molecules entering the liquid phase is equal to the number of molecules exiting the liquid phase. Then it is called saturated vapor pressure. The saturated vapor pressure is inside a closed box. So there is no relation between atmospheric pressure. What is the relation is only the temperature. So at whatever you say, saturated vapor pressure of halothane is 240 means it is at 20 degrees C. Saturated vapor pressure of N-fluorine is 175 means it is. We can't change vaporizers because you can see here, N-fluorine 4.3% is coming here, while halothane it is only 3.1% is coming to the bypass, but to the split portion. So we cannot change vaporizers. Another thing is about this, you need vapors. So because you cannot have a fluid which is an anesthetic, but it cannot vaporize. So you need to vaporize. So this is volatility is important. So saturated vapor pressure is important in that. When in and out are the same, SVP is volatility. So that is what is called as saturated vapor pressure. But when the temperature is 20 degrees, but if you go on increasing the temperature, the vapor pressure may increase here. So that is where the boiling point is. When SVP equals atmospheric pressure, then the liquid is at boiling point. Now, what is the molecular weight? Is the relation to, you have a low molecular weight, because low molecular weight goes into tissues without processes like active transport or facilitated diffusion, ATP remove, all these things are not needed. And molecular weight is inversely proportional to vapor pressure. For example, molecular weight and vapor pressure, this is not universal, but this is a simple logic. Low molecular weight, it is more volatile. Non-ionized, always, because neurons are lipids. Non-ionized is lipid soluble. That is what agents we want. Now, another thing is about the blood gas partition coefficient. How fast. See, should not be soluble in blood. It goes into the lungs, goes to the brain, creates a partial pressure, anesthetizes, comes out, goes to the lungs, and goes out. So this is what is called the blood gas partition coefficient. Only so much is necessary to create a partial pressure. But ether, if you see, 12.1 is the blood gas partition coefficient. That means it needs a lot of time to get in and get out. But these drugs are little less time to get in and get out. This is what the blood gas partition. Here, even in halothane, you can see. Yes, I'll come back to this again. This is about blood gas. Fast induction, low blood gas. Now we'll go to oil gas. Oil gas is basically somewhat related to lipid solubility. So if you have a high oil gas, lipid solubility, potency is good. If you have a potent molecule, then your MAC is less. That is what is important here. Methoxyfluorine, the oil gas is 950, MAC is less. Desfluorine, the oil gas is less, the MAC is high. This is what is about oil gas. Now, if you have a metabolism, so the drug should not get metabolized in the body. Halothane metabolizes 20%, N-fluorine 2.5%, sevoflurane 5%. This is what we want like. We want less metabolism. Halothane is 20% metabolism. We are the rare doctors, we use drugs through lungs. Now, all anesthetics are liquids, but we are using through the lungs. So it needs to get vaporized. So what all is facilitating your vaporization, that is what is necessary for an inhalational anesthetic to stay. Now we go to ether. Ether means it is in 2 carbon atoms. In between, there is an oxygen. This is what is called ether. Dimethyl ether. This is an ether structure according to the chemistry. Now you see ethyl groups. This is T2H5, OC2H5. This is diethyl ether. We call it this ether in anesthesia as ether. So this is not our ether. This diethyl ether is our ether. Now, you know, 16th October 1846, he demonstrated in an amphitheater the ether anesthesia by W.T.G. Martin. See here in ether, the blood gas partition coefficient is 12. When we used to give anesthesia with a tube and ether, we used to cut the agent before peritoneal closure only. Then only it will come out of ether and vomiting, nausea will be there. So this is the slow in, slow out drug. You can see the molecular weight is low, but the boiling point is well above. So no need to worry about the boiling point. The saturated pressure is good. It is good volatile. MAC is 1.92. Okay, simple, safe, and it is used for centuries. Ether, I have given a lot of anesthesia with centuries for decades. Put the tube, let the ether spontaneous, and after some time cut the ether and the patient gets out with the tube. So some analgesia is there. But what is the problem? It attacks plastic and rubber. Vomiting is quite common. It's inflammable. It is dense than air. So you can have flames along the floor. Not necessarily useful if you have an exhaust fan in the top. So flames along the floor. Blood gases 12. Slow onset, slow offset. Flammable. Attacks plastic. Vomiting. So we cannot continue with this because we are in the era of diathermy. Then they came out with Simpson gave himself the chloroform. Chloroform was invented because they don't want much of this thing, inflammation or inflammability. Snow gave analgesic doses of chloroform on a folded handkerchief to Queen Victoria in 1846, I think, 1843 or some correctly just to be deciphered. Victoria got his 8th child, Prince Leopold, and he told, fantastic, Dr. Snow, and he gave the blessed chloroform, and the effect was soothing, quieting, delightful beyond measure. So he called his chloroform Alaireni or Narcos Alaireni. Victoria really enjoyed. And what happened then? Because she enjoyed, she came out with next 9th child. And Snow was continuously giving again. And Princess Beatrice was born in 1848. But what happened then? Victoria must be ready enough to give the 10th. But unfortunately, Snow died in 1852. So we don't know what has happened later. Chloroform, am I audible? Sir, am I clear?
Yes, Partha, you are clear.
Yes.
Yeah, you are
Yes,
clear and
Partha,
audible.
yes.
You are clear.
Chloroform could also be mixed with other anesthetics such as ether to make combined chloroform ether or ACE mixture. These was are not having explosions. Chloroform was okay, but it was having liver and cardiac toxicity. So then they came out with ethyl chloride and ethylene. See, when I was a child, the paranoia was there. One MBBS doctor, he sprayed something. I remember still, and some 6 years or 7 years old. And he nickeled it. There was no pine, it was chill. So this ethyl chloride spray, then we found out this is ethyl chloride stuff. I don't know whether they invented in Chicago greenhouses. They sprayed this ethyl chloride and there was no budding of the flowers. Then it is this ethyl chloride is doing something for everyone to sleep like. So then they found out this ethyl chloride can be used after the plants to the human beings. So this ethyl chloride and then ethylene, they are all explosives again. So cyclopropane came into the picture. Cyclopropane was propylene in steel cylinder produced so much toxic substances. And one was this cyclopropane, and they stored in orange cylinders. And people might not have seen these cylinders, a small cylinder. 17.5 is the MAC and the blood gas of 0.55, but it produces cyclopropane shock and arrhythmias. It was so toxic to the heart. And it was given as a demo to Banting, Banting and Best, the inventors of insulin. He was ready to receive the cyclopropane. So cyclopropane shock was my exam question in those days in 1990s. So cyclopropane was slowly moving out into the dustbin because of explosions. Okay, then they came out with the trilene. This does not explode. I want trilene, fine. But phosgene was produced in soda lime. They slowly came out with closed circuit, soda lime and all these things. And this trilene cannot be used because it produced toxic substances. Now we have, then they came out alkanes. Alkanes is what? CH4, C2H6, etc. Methane, ethane, propane, like that, butane, hexane, pentane, etc. So this has got a cutoff effect. For example, propane, it is not much anesthetic effect. So if you have butane, octane, they don't have anesthetic effects. So the carbon molecules should be less. This is what is called the cutoff effect. Now they don't want explosion. They want good thermal and chemical stability. It should not be degraded by heat. It should not be degraded by adding some chemical. It should be less toxic, more stable. Then what was the answer? It should be just like this, the picture. They came out with fluorine. Fluorine, bromine, iodine, chlorine. These are called halogens in chemistry. So they added halogens, fluorine, to inhalational agents, especially alkanes. So the first fluorinated anesthetic was fluorine because fluoroxine, but the metabolite, is toxic to the animals. So this fluoroxine slowly went out. And in 1953, Suckling created halothane. This is nothing like that. Ethane, methane, propane, marriage. This is an ethane, which is halogenated. Halogenated ethane is called halothane. And when they came out, they called it as fluothane because it was mainly fluorinated. But it is now, see here, this is ethane predominantly. What is only ethane, but you have a lot of halogens like chlorine, fluorine, and bromine. This is halothane. It is very less expensive, volatile anesthetic agent, good. Saturated vapor pressure is 240, volatile. We have got an oil gas of 224, NF potency, MAC of 0.75. Blood gas is 2.1, slow slightly. When we have giving halothane, you have to cut your halothane. Previously we used to do at the time of rectal sheath only, before skin, in the laparotomies. So it will take some time to come out and come up like. No flammability, fast induction, sweet smell, because previously halothane was, before the advent of sevoflurane, pediatrics was anesthetized with halothane. Yes, good, no flammability, fast induction, sweet smell. Why can't we continue with halothane? Thymol is needed. Why not 1% thymol is added to that? You would have seen that bottle. It is amber colored because it is UV radiation instability. You could have seen a dark amber colored small bottle with 30 ml, 50 ml of halothane. Another major problem is it sensitizes the heart to exogenous and endogenous catecholamines. Produced arrhythmias, slow slightly went out, and it was hepatotoxic, and the metabolism was 20%. We don't want metabolize. It has to come in and go to the brain. It could create a partial pressure, act on it. After you discontinue, come through the lungs and get out. This is what we want. The switch was on and on. They came out with methoxyfluorine. Methoxyfluorine, already we saw the oil gas is 950, extremely potent. MAC of 0.16, see here, but the blood gas is 11. So it goes in slowly. Saturated vapor is not volatile only. Saturated vapor pressure is 22. And one more problem was it was metabolized and it gave the fluoride induced to nephrotoxicity. All these things were dangerous. So there were three factors with the thinkers of chemistry. We don't want much carbon, less carbon, because more carbon means volatility is gone. We want hydrogen to be less. This is less inflammable. We want it to be less metabolism. Ether, flammable explosions. Then they came out with alkanes, halothane. It caused metabolic degradation, hepatotoxic, and arrhythmogenicity. Then they came back to ethers because you remove the flammable portion and produce an ether, and this ether is not going to be arrhythmogenic. This is going to be safe to the heart. Then they came back to ethers. So then came N-fluorine and isoflurane. What is N-fluorine? It's a non-inflammable fluorinated ethyl methyl ether. Fluorine is there, this side ethyl group, that side methyl group ether, that's all. Boiling point is 56, just more than above that. You can see blood gas is 1.9, good. Oil gas is 9.7, okay. So scientists came back to ethers to avoid arrhythmogenicity. But N-fluorine was a negatively inotropic somewhat. So, but it was potentially seizurogenic or convulsant. You can see this is C2H5. This is what is called our diethyl ether, original ether. This is also ether, CCO, but it is, you can see, fluorinated methyl ethyl ether. This is also fluorinated methyl ethyl ether. Here you can see ethane, halogenated ethane. This is double bond is there, so it is ethylene. Then they came out with isoflurane because of the seizure-convulsant potential of N-fluorine. Yes, you can see fine, the vapor pressure is fine, it is volatile. It is, see, isoflurane is a name because it's a chemical isomer of N-fluorine. It's an isomer of N-fluorine, that is why they termed this as isoflurane. It was a delayed entry because of some carcinogenic fears. You can see isoflurane and N-fluorine, the isomers. It has minimal cardiac depression, heart rate increased by 10, baroreceptor reflexes were intact. There is a mild beta stimulation. The rate increased by 10 to 20%. But all these things were very fine. Only the problem was the pungent ethereal odor. This was relatively not good for an inhalational induction. This was probably one of the causes. It was slowly slowed down, but still it is being actively used in many centers. Boiling point of 48.5, saturated vapor pressure is fine, volatility is fine. Blood gas is only 1.4, fast in, fast out. Yes, you are a MAC of 1.1 or 1.2. Metabolism is 2%. Yes, the problem is also the so-called fear about coronary steal in isoflurane. So then came another couple. This is sevoflurane and desflurane. N-iso-sevo-des. See, you can see the N-fluorine length. They have removed this chlorine. They don't want chlorine is causing some problem. We will have only fluorine because we want stability. This is only achieved by fluorine only. So we have only fluorines. So desflurane and sevoflurane has no chlorine, has no bromine, all these things. So only fluorine is there. There is a small difference. This is methyl ethyl. This is dimethyl. This is what is a small difference between sevo and des. Now, sevoflurane is got 7 fluorine atoms. That is why it is called sevoflurane. You can see F3, F3, and F. This is about 7 fluorine atoms against the name. Yes, it allows sweet smell to allow smooth induction. It is now the induction of choice in pediatrics. Yes, the fast induction and recovery. The greenhouse effect, this is called the global warming potential of 345 is too less. That is what we don't go into the details. Now, sevoflurane, yes, the blood gas is 0.6, very less. Oil gas is 55, MAC is 2. Fine. But there is a degradation about pseudolime. The fear of compound A was there. But numerous evidence have now shown, even in low flow anesthesia, even with a desiccated Bara line or a dry soda line, even for 5 to 6 hours, this compound formation is far 5,000 times less than the so-called described toxic levels. So this compound A fear is now disappearing. So sevoflurane has got a good oil gas, a MAC of 2 only, and blood gas is 0.6 only. Think of blood gas of ether is 12. Blood gas of the sevo is 0.6. Blood gas of nitrous is 0.4. So this blood gas is for fast induction and fast out. Now you have a desflurane. The blood gas, see here, fast in, fast out. Oil gas is very low. Think of oil gases. Methoxyflurane is 950. Now here, because it is less potent, you need a MAC of 6 for the patient to give anesthetized. But the problem here is the boiling point is 22 only. Sometimes if the temperature goes up in the theater, it will boil. So there is no use of a routine vaporizer. So you need a specialized vaporizer for desflurane because you need a heated chamber and it has to consistently and constantly give vapor, whatever be the you set the thing and whatever be your flows. Desflurane is irritant to airways. They don't use for inhalational induction. They say it is more a cause of pediatric emergence delirium, slightly cause on the more side. Carbon monoxide formation risk was alleged, but insignificant. So now the problem with desflurane is only about irritation to the airways. There is an increased incidence of emergence delirium and probably the cost, mostly due to the cost effectiveness of your Tech 6 vaporizer. Switching over, they have found out switching over from isoflurane to desflurane towards the end doesn't matter much. Okay, you are given isoflurane for 1.5 hours. Last 10 minutes, I am giving desflurane. Okay, this has not been much effective. Desflurane emergence has been associated with the delirium, and some described test studies are there. Even there is a tachycardia during induction with desflurane. You can see here the halothane only at 2 MAC is coming down there. Cardiac output. All these things, the maintenance of cardiac output is there with isoflurane, desflurane. UV stability. All these things are in UV stability. Halothane needed, amber colored bottles, and thymol. These are doesn't necessary. So actions of all anesthetics are same. It causes general anesthesia. There are so many mechanisms described. NMDA, GABA, glycine, so many things. A slight increase in CBF and ICP. a decreased CMRO2. Right. So depresses respiration, bronchodilator, decreased hypoxic response, and negative inotrophy and vasodilation. There are subtle changes. Some anesthetics may be a better bronchodilator. Some anesthetics may be a less negative inotropic. Some anesthetics may be a better vasodilator. Some anesthetics may not affect the CBF and ICP much. All these things are slightly different, but action is almost similar. They are uterine relaxants. Relative contraindications are malignant hyperthermia, increased ICT, and severe hypovolemia, where we need good volume resuscitations. We don't know when he will come, maybe in January 1. It was first used in 1951 by Cullen on an 81-year-old man having an orchidectomy. Blood gas of an, see here, blood gas is 0.15, 0.4 for nitrous, 0.4 for some desflurane. Here you can see 0.1, so fast, go in, go out. 60 to 70% is the max, 60% you have to give. No nitrous is necessary because it has got some analgesic activity. Give oxygen 30% to 40% is okay. Fast in, fast out, no metabolism. There is some analgesia, no fingerbuxia, no worry about malignant hyperthermia. Stability is fine. So everything is fine except the cost. Even prohibitive cost, even in foreign countries. So it has to be restricted. Now we go, see here, the blood gas is important for fast in and fast out. The boiling point, it should not boil at room temperature. Desflurane is a problem. You need a tech vaporizer. Oil gas, here it needs potency. And oil gas is only 26, area potency is less and MAC is high. Metabolism is 5% for sevoflurane oil, is only 0.02% for desflurane and 0.2, while it is 20% for halothane. This is what again I'm telling, the different slide. So contraindications will go that these are all given in textbooks. Venous arterial thrombus, pneumothorax, acute, so many things are there. Unexplained liver functions for halothane, isoflurane, asthmatics. They are all relative contraindications. Now, what is the summary about? They found out ether. First and demonstrated 16th October 1846. Then they used for decades. Then they was inflammable. So they came out with halothane. This halothane was having rhythm disturbance. This alkenes was not anesthetics at higher alkene carbons. The volatility was decreased. So they went back to ethers to decrease the rhythm disturbance. They have methyl ethyl ethers, methyl methyl ethers. There was no stability, so they added halogens. There was a lot of problems with metabolism in other halogens, though they picked up to fluorine. And fluorine has to be stuck in with this carbon molecule because if it goes out, it can cause fluoride toxicity. That is what is the stability is all about. Blood gas partition coefficient, yes. Low means fast in, fast out. As metabolism, less metabolism, desflurane is very less. Sevoflurane is at least 5%. What's the carry home message? Letter from my daughter on my birthday when she was 5 years old. Now she is 17. My gift to the parents to obey them. Enjoy life's precious moments. Thank you all. Thank you. Thank you, sir.
Thank you, Partha.
Thank you. Moderators, please take over, please.
Patsati, as usual, it was a very succinct lecture and all the essential features were covered. And I think what postgraduates need to know and possibly what practicing anesthesiologists need to know also have been very well driven home. I was looking at the chat for questions and there seems to be one question. If I can read it out to you. Patsati, can you hear me, right? Partha, can you hear me?
Yes, sir.
Yeah, the question is from Dr. Kamachi Selvam, and it says, is there any suggested better agent for post-COVID-19 general anesthetic procedures?
No, what is the difference, sir? I don't understand. This is
no, the question. I shall rephrase the question. The question, I believe, is there any special agent that is ideal in the post-COVID state?
Not reported, sir. Not.
I also agree with you. And Dr. Kamachi, if you're satisfied with that answer, fine. Otherwise, please come on to the unmute yourself and
No, sir,
continue?
we don't encourage the delegates.
You don't do that. You don't do that. Okay,
So
fine.
we will.
So I think I also agree with
moderators
the-
will give their opinion and conclude. Yeah.
Okay, fine. So if I may add on to what Dr. Partha said, it is not the anesthetic agent, the volatile agent that is specific. COVID has got several other issues related to it, and I don't think we should be talking about that now. But as Partha rightly said, there is no specific agent that is useful in COVID-19. There's a question from Vidya. Is emergent delirium in children significantly less with sevoflurane than desflurane? I
Yes.
repeat, Partha says it is yes. Is emergent delirium in children significantly less with sevoflurane than desflurane? Yes, agreed. Next question from Shanti. Oh, it's only a comment, not a question. Excellent presentation, Partha, sir. Complex topic made so simple for PGs. I should also go back onto the chat and see if there's anything else there. I don't see any specific questions aimed. So, Sudarshan,
Sir, is there?
yeah, are we allowed to just
Yes, yes, sir. A lot of things. That is why you are here.
Okay, great.
Yeah, your clarifications, everything. Yeah.
Right. So again, as Parthasarathi said, the evolution of inhalational anesthetics, if the pharmacist was looking, or the people who make the drug molecules were aiming to create new molecules, they were trying to create molecules that were having less side effects. So essentially, if you want to sum it up, we wanted an agent that would act on the CNS, that is cause unconsciousness and pain relief, without causing the unwanted effects on the respiratory and the cardiovascular system. And that is how the evolution has happened, starting with the ethers, then with the alkanes, and then eventually the halogenated ethers. And as Parthasarathi explained, the objective of the people who were working on these molecules was to try and minimize the side effects, especially on the cardiovascular and on the respiratory system. I think as a parallel, when we look at the development of inhalational agents, we can also look at the development of vaporizers, which are the devices that create these or convert these volatile agents into an inhaled format that can be delivered in through the lungs. And therefore, vaporizers also have become, as the drugs have become more potent, vaporizers also have become more precise. And the precision vaporizers, I think some of the practitioners in this group might have used the modern vaporizers, the injection vaporizers, which are used for, in some machines, where the very potent agent is injected in very specific quantities. The idea being that you calculate it with predetermined formulae, inject the drug into the system, and then it vaporizes. And instead of giving it to a vaporizer itself, which generally we tend to err on the side of overdosing the patient. So injectable drug, the volatile agent is injected in small quantums, ranging from 0.2 to 0.3 or 0.5 ml, and at predetermined intervals using formulae. This basically builds up the anesthetic concentration in the closed system and creates the anesthetic very fast. And similarly, if you give less of the agent, the recovery also is faster. This is just one point I wanted to make to add on to what Parthasarathi had mentioned. Parthasarathi did mention that term, fast in, fast out. So that can be achieved by one modifying the molecular structure of the drug. The other thing is also by the way we administer it. We inject only small amounts. Only what is required is injected, and therefore the body doesn't have too much of a problem getting rid of that volatile agent. And it is always better that we have an agent that is less metabolized. So it goes in and it comes out without needing to undergo metabolism, and therefore the recovery also is faster. Not only do we want everything nowadays is very quick gratification like that. So you want quick anesthesia, quick in and quick recovery. So all these are, I think, the goals which are set by pharmacologists who are developing new molecules. Okay? That's one thing I want to add on. Does Mubarak have anything to say? Otherwise, I have one more point to make after Mubarak. Or anybody else? Are others allowed to, Sudarshan, or anyone else allowed to? Yeah. Please ask your questions. Unmute
the moderator, Edward, yes. Yeah.
Sir, I have one question.
Let Dr. Mubarak complete it. He make a comment.
Dr. Parthasarathi, good morning.
Good morning, sir.
Good morning. Good morning. Yeah. There is a question. It was a nice presentation you took from nitrous oxide to xenon through various inhalation anesthetic agents. And Just there's one question in the chat box. It has come right now from Dr. Robin Sargent Chaco. That is, he asked whether it was mentioned that volatile anesthetics are respiratory depressants. Is it dose related or do they depress even at the MAC doses? That's what he has asked.
Yes, it is dose related and they depress at MAC doses.
Then another question has come from Dr. Leo is, does the inhalation anesthetic agents affect the cognitive function?
So that is what is being studied in children for so much things. So that's a big different this thing. This is not related to the topic, I think. Dr. Ramkumar sir.
See, there are two questions. One is volatile anesthetics are respiratory depressant. Is the dose related, or do they depress even at MAC doses? Yes. The very term dose related means that as the dose is increased, the effect on the respiratory system is more. So we are looking for that magic agent which creates central nervous system depression without depressing the respiratory system. And therefore, the answer to that question is yes, even at MAC doses, the respiratory depressant effect will be there. Okay, and that question is answered. And does it affect cognitive function? Not on a long-term basis, unless there has been an anesthetic mishap intraoperatively. Anesthetics per se, volatile anesthetics per se, do not, if you used it in a safe manner, the patient should come out in such a way that they have the same cognitive function. Having said that, in the elderly, we know that in the central nervous system, there are certain watershed areas. And if your anesthetic results in a reduction in blood pressure, okay, it is a reduction in blood pressure that actually affects these watershed areas in the brain. And transiently, maybe for days or weeks, the person may have an altered cognitive function, particularly the elderly. But I think the younger age group, no. Partha, you mentioned about the younger age group. I presume you're talking about in the developmental stage of the brain, especially in neonates and premature neonates. When we use volatile agents, we have to be careful because we yet do not know what are the long-term effects of anesthetics on the development of the brain. And therefore, I think that question is definitely to be kept in mind. Once you have, let's say, beyond the age of 2 or 3, when the CNS development is more or less complete, then they behave like adults. So the extremes of ages, very young age and very old age, it can affect the cognitive function. It can also affect the brain development. I don't know whether that has answered that question. Let me see this one more, I think.
Then one practical question has come from Dr. Bharati. That is, can we use isoflurane in old halogen vaporizers since they have similar vaporization characters? Dr. Parsarthi,
yeah.
I think because halogen has a unique feature of having thymol in it, and which will cause problem with isoflurane.
I think can take that question. Mubarak, we'll add on if there's anything required. Huh? Partha, the question from Bharati, isoflurane, can it be used in halogen vaporizer? Partha, are you still with us? Okay, I think Partha's...
No, please unmute Dr. Parsarthi.
I don't see Partha also.
No, yes, we can speak now, yeah.
Yeah.
Exchanging vaporizer is not allowed. I don't recommend anything. You put halogen into this thing and all those things I don't recommend. That should not be used. Isoflurane into N-fluorine, all these things is not allowed.
He has asked specifically halogen and isoflurane.
Yes, this is all because the saturated vapor pressure is similar. When the saturated vapor pressure is similar, the splitting ratio is similar. When you have splitting, for example, if you give a 4-liter gas supply of this thing, if 100 ml will go here, 3,900 ml will go there. So this is bypass. So if the splitting ratio is similar, can be used. This was a question, but it is not recommended.
And as a policy,
Bharati is available. Can Bharati please unmute and come online, please?
And as a policy, vaporizer agent should be interchangeable. That's why we have key filling devices.
Yes.
Not to change one agent to another vaporizer. And in addition, halogen has thymol as a preservative, which will cause stickiness and problems. And there is no question of changing the vaporizers with the different agents.
Dr. Bharati, your comments, please.
Yeah.
Oh, so Bharati has come online, is it? Has Bharati come online?
Yes.
Okay,
Yes.
please, Bharati is the answer.
The thing is, the issue of thymol is only for tech vaporizers. where Goldman vaporizers are being used still in the rural and semi-urban areas. Goldman vaporizer is just a glass bottle. Just wipe it with the tissue paper and pour your isoflurane and use it. And after all, whether you use halothane or isoflurane in Goldman, your titration is based on clinical effect, not on the dial. So I do use it. I do use it. I don't have any problem with that. And I am working in a remote location in a hilly area. When I was a registrar in the UK, I had picked up halothane Fluotech 2 Mark II vaporizers, which are still working very fine. And after a long gap, I'm using isoflurane in Fluotech without any issue. There's no problem at all.
Yes, sir. Hello.
Thank you, Bharati. Partha's response, please.
Yes, I have also used, but that is not to be told in the this thing of a CME like PGs. No, I have also used ether, halothane, isoflurane in a bottle, Goldman vaporizer. If you have a good clinical acumen to anesthetize, yes, we can do. But the tradition or what is the convention to be told in the CME is avoid exchanging vaporizers.
Absolutely right. I think so. And also, we're not monitoring the expired gases and things like that. So we don't know how much we are delivering with these kind of ungauged vaporizers. The maximum you could give is up to 2.5 is the dial setting it shows on the Goldman. But realistically, it depends on the fresh gas flow rate. So you're not very sure how much you're delivering to the patient. And unless you monitor the expired gases, you may overdose these patients and cause a lot of ill effects. That's my opinion. And Edward had one question. I think he can continue with his question.
My question.
And we'll have another 2 minutes to conclude this session.
Sure.
The next session has to start. Edward, please.
Before wind up, my last question to Partha. Really, is the coronary steal syndrome exist in isoflurane? It is a old concept around the 1980s, I think.
So, see, they thought of that like that. Yes, am I audible?
Yes.
They thought of that like that and they switched over to making some other drug like. So it was a problem like now it is gone.
Yes.
They thought like that isoflurane and they came out with newer chemicals.
Now they are saying it is as a preconditioning effect and it's
Yes, this coronary steal with isoflurane is presently in science not existing. Correct only you are.
Any comment for Ramkumar, sir?
Yes, I think I will. May I conclude with my concluding remarks? The
Yes.
time is running out.
Yes, sir.
Yes.
Okay. So, Partha at the start of the session said that the moderators will add on to the recent updates. So I was tempted to say this. I read recently that, volatile anesthetic agents are now being something like we had encapsulated hemoglobin, something like that. They are now working on formulations that can be injected intravenously. Now, a time will come when we'll be using specific formulations of volatile anesthetic agents in an injectable format. And when I say injectable, I mean intravenous injection, which will not have the adverse effects. So formulations are being created now. Once again, we are trying to become more and more precise. We'll inject a very precise amount of drug into the intravenous compartment. Obviously, the molecule is modified enough not to cause any adverse effects, and it will go directly to the brain and cause the anesthetic. So this is probably where we're looking at maybe 10 years down the line, when volatile anesthetic agents will also be available in an injectable intravenous formulation. It sounds like science fiction now, but this is something for us to think about when we sign off on Partha Sarathy's session. Thank you very much, Partha, for a wonderful session and for getting us thinking. Thank you.
Thank you, sir. Before we start the next session, I think delegates, please note the WhatsApp number, which has been displayed just now, to please send only your name to this number as a WhatsApp for applying for the credit points. Once you send your name alone, you will be getting the details tomorrow how to proceed with applying for credit points. So send only the name. Do not enter your name or details in the chat box. And don't send a SMS message, but send a WhatsApp to this number. Thank you. Over to moderators.
Okay, thank you. We welcome the second speaker, Akshaya. Mubarak, sir, please.
Yeah. Next speaker is Dr. Akshaya Shetty. has done his UG as well as PG from Belgaum in Karnataka, and he has done his fellowship in cardiac anesthesia also in Belgaum, and he has done Indian diploma in regional anesthesia in 2018. He's working as an intensivist and cardiac anesthesiologist as cardiac anesthesiologist, associate professor in Department of Anesthesiology at Pravara Institute of Medical Sciences, Rural Medical College, Loni, Maharashtra. And he has worked as cardiac anesthesiologist and assistant professor in Department of Anesthesiology and Critical Care Medicine at Mahatma Gandhi Medical College, Puducherry, in September 11 to February 2013. And he has also worked as cardiac anesthesiologist and assistant professor in Krishna Institute of Medical Sciences, Karad, Maharashtra also. And he has to his credit so many publications. And Doctor, he is taking us to the topic of airway management in special situation. The topic given is can see the larynx and can't intubate, managing the crisis. Over to you, Dr. Akshaya, please.
Thank you, Mubarak, sir. Good afternoon, everyone. Am I audible?
Yes, sir.
Yeah, you are audible.
Yes,
You are
yes.
audible.
Yes.
Thank you to all the organizers and Dr. Parthasathi sir for considering me for this interesting topic. Though I have a little experience on this, but I'll put my best of it. I can see the larynx, but I cannot intubate. We term the coin it is as a calci is probably a new word in the book. Probably it may enter. Let us start with some basic things. Intubation is nothing but an insertion of an artificial tube into the patient's trachea for ventilation. It might be for the elective or emergency situations, and it extends from the newborn till the elderly person. We do intubation for on day-to-day basis, especially in the operation theater, ICU, or in the emergency department, and even in general ward also whenever it is required. Coming to the facts, there are more than 700 people die every year in developing countries, though it is underreported, which is related to the airway management. And you just imagine what will happen in the underdeveloped countries where they have the lesser amount of facilities to manage the airway. More than 95% of the difficult airways can be identified with the careful assessments. The assessment of airway can be done in a different way, like Mallampati grading, upper lip bite test, theromental distance, thiomandibular distance, sternomental distance, Lemon scoring, interincisor gap, and neck circumference, mouth and mouths, and radiological assessment. Especially nowadays, the USG is being used for the airway management also. I'm not going in detail about this airway assessment. Now, little about intubation. There are 3 axes for managing this intubation procedure. That is oral axis, pharyngeal axis, and laryngeal axis. When patient lies in supine position, all these axes are not in line. The moment you elevate the head by putting the pillow by about 10 centimeter, the pharyngeal and laryngeal axis becomes in line. It will create little flexion at the neck by about 35 degrees, but still the oral axis is not in line with the other 2 axes. By putting in a head in extended position with the pillow below, all the 3 axes becomes in line, and there will be severe, nearly about 80-degree extension of the head on the neck. So all these planes, once it becomes in line, the intubation becomes much more easier. So keeping the head extended without the pillow, again the axis of oral axis will not become in line with the pharyngeal and laryngeal axis. Now coming to the patient position, Suppose there is one study suggesting that if you keep the patient at the Xiphide level, the intubating conditions are much better when you compare it to the patient keeping at the umbilical level. Now, the stooping of the operating person is not good because it may not help for the lifting the blade with shoulder strength, and even that person may feel the back pain in later phases. And keeping the eyes very close to the larynx or to visualize the laryngeal area will interfere the depth appreciation. Now, after positioning the patient, open the mouth as shown in the figure, hold the laryngoscope as shown in the figure, introduce the laryngoscope blade in the mouth from the right hand side and move the tongue onto the left side. Never rotate the blade back onto the teeth, and always keep the back straight. Don't try to rotate the left wrist, and try to lift the blade up and away for the better visualization of the glottis. Now, always keep your shoulders relaxed. If you are using Macintosh curved blade, ensure that the tip is at the vallecula, and if you are using the straight blade, and you are going to catch the epiglottis tip also. If at all you are raising the arms, it is a poor technique. You are forced to rotate your wrist, and you will not be able to lift laryngoscope blade so easily. Now, these are the improper positioning of the patient, which will lead to iatrogenic difficult intubation, which is seen most commonly with the beginners, keeping the pillow below the shoulders or saline bottle below the neck, saline bottle below the shoulders, not maintaining the adequate height of the table or the cot. And very important thing is not detaching the head and panel, especially I see these things in the ICUs. Improper laryngoscope blade insertion also causes a problem for intubation, and even improper selection of the size of the laryngoscope blade, and not shifting the tongue to the opposite side, and not lifting the handle. So training these beginners in the skill or simulation lab will definitely help, and experienced anesthesiologist should be available when it is really conducted on the patient. This is again important thing. Improper light source, which is a most common problem on day-to-day practice. We do come across with a poor light source laryngoscope blades are kept, and which are having discharge power. In emergency, it is again difficult to use these things. In this case, you may see the larynx, but may not be so satisfactorily to intubate the tube, intubate the trachea. So how to prevent or solve? By making a regular pre-intubation check in emergency department, ensure that daily check is done, have an alternate laryngoscope blade and power supply also. You can use LED type of white light for intubation. So coming to the topic proper, one can see the larynx but cannot intubate. My topic is like, it's not actually purely a difficult airway. You are now able to see the larynx, but you are not able to intubate. So there are certain scenarios. I have listed some which are really practical. I will speak on this. Improper airway assessment or anatomical abnormal upper airway. That is, you are planned for a surgery and planned for the nasal intubation. And in such cases, like you have not seen the patient properly, or not a proper history has been taken, and that time, like for example, severely deviated nasal septum or hypertrophic turbinates, and unexpected mass in the nose or nasopharynx, this will lead to the problem for the intubation. So how to resolve? So ensure that you do the proper history taking and examination by a spatula test or occlusion test. If unable to pass the endotracheal tube through the nose, for emergency basis, you can convert it to oral intubation. Or if you are given a very short acting muscle relaxant, you can go ahead with the mask ventilation. And if it is really emergency and not able to do oral intubation also, you can think of a surgical airway. Traumatic upper airway, especially in road traffic accidents, the base of the skull or nasal bone fractures are very common, which are most commonly posted for the oral surgeries. So proper history taking and examination is again important. If you are unable to pass the tube through the nose, you can think of oral intubation as a retromolar tube insertion or submental conversion of the oral intubation. One important thing I want to inform to the postgraduates that the endotracheal tube should not be inserted in an angulated manner when you plan for the nasal intubation. This is because if you see the anatomy, the floor of the nose is actually vertical to the spine when patient is lying supine position, and not in an angulated manner as shown in the red arrow. It should be inserted as shown in the green arrow. Once you are clear with this anatomy, and once you are intubating with no problem, you are doing the laryngoscopy and you can see the cords. After the insertion, there will be a bleeding. The possibility of bleeding is there, and now your vision on the vocal cords will go off. So how to tackle this issue? Proper preparation of the airway is important, using alpha agonists like xylometazoline and using nasopharyngeal airway for dilatation along with and also you expect some amount of bleeding. So keep suctioning also ready. Now, sometimes you are able to see the larynx or the vocal cords, and you may not be able to push the tube properly. Whenever you are planning for the nasal intubation, that time you can take the help of the assistant to push that tube inside, or you can use the Magel forceps to direct the endotracheal tube into the larynx. And sometimes it may help, flexion of the head will help to direct the endotracheal tube into the larynx. Suppose endotracheal tube is at the larynx, and it may get obstructed by the epiglottis. So at that point, you can do the jaw thrust, rotate the tube bevel so that it will point anteriorly, and easily you can insert the endotracheal tube. So if it is at the anterior commissure, flex the head and rotate the tube and re-advance. If it is at the piriform fossa, then it is you have to make a rotation on the contralateral direction and re-advance. Now coming to the next scenario, where protruding incisors are commonly seen, and in that case, sometimes paraglossal approach using a straight blade is done, but it is very important to select appropriate size of endotracheal tube and also ensure that adequate muzzle relaxant or sedation are given. Improper size selection of endotracheal tube, again, it's a common problem. Without having knowledge, if somebody is taking the endotracheal tube of a bigger size for children or for an adult male or female, then you will be able to visualize the larynx or the vocal cords, but you will not be able to push the endotracheal tube smoothly. Again, an inflated endotracheal tube, some manufacturers definitely give endotracheal tube in a mild inflated state. And after laryngoscopy, you see the vocal cords, but you may not be able to put the endotracheal tube into the trachea because it will act as a little resistance, and you can deflate and put some lubricant on it for the smooth intubation. Improper sedation and or muzzle relaxant, it is most commonly seen in ICU setups, where there is a hesitation or anxiety to use these drugs because of some poor facility, if at all, especially in the rural setup and all, if you have that. So, or there is a lack of knowledge about the drug used, or inadequate mouth opening is there, and there will be an intact cuff reflex or gag reflex and closing position of the vocal cords. All this will interfere in the intubation. So how to prevent this? Have a protocol-based approach, understand the drugs you used before, and proper training in skill and simulation lab will prevent this. Stellate-related problems, because of inadequate length, either it is too small or too big, or improper shaping, that is making the tube in too much of anterior positioning. So how to solve? There are three types of stellate which are available in the market. One is neonatal, second one is pediatric, and third one is the adult. So proper shaping will definitely help the intubation. So if all the three exist, which I have mentioned earlier, if they are in line, there is no need of using the stellate. and it is really unnecessary. You can use Macintosh laryngoscope blade and you can intubate the patient. Whenever you feel a complicated airway is there, then you can angulate the endotracheal tube. You can use hockey stick type of shape. That is till cuff there is a straight, and after that there will be 35 degrees angulation is made. Or you can use the arcuate shaped stellate. So there are study conducted, and it has been showed that arcuate type of shape is going to help smooth intubation in most of the patients. Improper bougie insertion, excessive force on the bougie. This is again an important thing. You'll be able to see the larynx, a small part of the larynx, but you are not able to push the bougie, and somehow you forcefully push the bougie into the the muscle part of the pharynx or into the esophagus. So it is a wrong entry of the bougie. So under direct vision, the bougie has to be intubated, not in a blind way, and there should not be forceful insertion of the bougie. And always insert the endotracheal tube that over the bougie. Suppose bougie is in place, but you are not able to introduce the endotracheal tube. It may be because of the wrong selection of endotracheal tube, or inadequate mouth opening, or unparalyzed vocal cords, or obstructing epiglottis, or glottic edema. So how to resolve this? Always have a correct size endotracheal tube, or you can keep a smaller tube sized tube also. Inadequate mouth opening, you can paralyze the patient. Glottic edema, again, you can treat the edema if it is elective. If it is emergency, you can think of a surgical airway. And if it is obstructing epiglottis, you can do jaw thrust. Improper insertion of the tube, again, it is iatrogenic calci. If you are intubating in the midline itself, then you are obstructing your view. So insert the endotracheal tube a little lateral to the medial side. Last tongue, again, you lift the tongue in a proper way. Little more force is required to improve the vision. Anterior placed larynx. This is a common scenario. It is a misnomer. In the laryngoscopy, you can see the epiglottis, or part of the glottis can be seen. And deeper and unreachable larynx appears situated anterior to the line of sight. But it may be because of large hypopharyngeal tongue that causes the difficulties. So it is actually speaking, it is a caudal larynx instead of anterior placed larynx. So ensure proper positioning of the patient. Mild or moderate pressure, external pressure will definitely help in visualizing the glottis. And too much of pressure also makes it difficult to intubate. Glottic edema, it may be because of trauma or anaphylaxis or prolonged orotracheal intubation, or because of the infection. Always treat the cause. If it is elective, treat the cause. If it is emergency, and you can consider a surgical airway. Post-glottic stenosis, like Webb, or because of the trauma, or because of the tracheostomy, there might be a stenosis. In case of managing this case, always have a proper history taking and examination. In case of elective, you can go for a smaller size tube. In case of emergency, you can think of surgical methods. Central line induced by using improper technique, or a patient who is on anticoagulant and inappropriate size selection of the central line catheters, which will lead to the bleeding in the neck and compressing the trachea. Visualization of the larynx itself is difficult. Even if you visualize, it is very difficult to push the endotracheal tube. Always check for the coagulation profile, proper sized central line selection, and you always try to use UEG guided central line insertion. Sometimes it may the external pressure may help to intubate the patient, or surgical airway can be considered in such a situation. Tumors or swelling in compressing the trachea. Thyroid gland related swellings are also common, and that might be there might be a space infection spreading in the deeper layers and compressing the trachea. So it might be intrinsic stenosis or extrinsic stenosis or mixed stenosis. Have a proper assessment and history. Pulmonary function test will help in identifying this, and you can go for fiber optic intubation. If it is thyroid swelling, you can lift the swelling and open the space and intubate the patient. And the last one is in the pediatric patients. if you are visualizing the glottis, a part of it, it can be improved by the hand-assisted elevation and caudal traction of the shoulder during tracheal intubation in pediatric patients. So there will be a little improvement in that view. So these are my references. Thank you.
Thank you, Dr. Akshay, for your practical aspects and your nice slides. I would like to add one or two things from my experience, because if we have a good assistant, that will be the blessing in this situation.
Yeah, in anesthesia, it is a blessing, sir.
Yeah,
The
that is
assistant is very
the
important.
best aid is the good assistant, and he can manipulate the larynx according to your requirements, which will help. That is one thing. Then another thing, especially in pediatrics, which I have found is, once you do the laryngoscopy and visualize, and if you think it is difficult for you to intubate, I ask the assistant, I hold the laryngoscope in that position and visualize the larynx, and I ask the assistant to intubate with the laryngoscope placing by myself.
This is very true. This happens
that I have
in experienced person, especially in rural setup, when juniors do come with us with a little experience in the pediatric patients, especially newborn and all. So I give proper position and ask them to intubate. I think the assistant is very important. He's a he plays a very important role.
Yeah, that will be a good way of teaching for them also, for juniors.
Yes.
And that will, instead of yourself trying to do the laryngoscope as well as intubating the other person, but it will be a little difficult to share the head in the newborn. But many a time I have found it very useful and a good teaching method also.
Sure.
So okay. A few questions has come from the chat box.
Sure,
for newborns, although the straight blade is the recommended one, what is the ideal one in practice according to you? What is your take on video scope like AirTrack on infants? Practically, from personally, I always prefer the routine curve.
Mubarak, let the question be answered by Akshay. Did you get the question straight, Akshay? First question is,
yes, sir.
Straight blade is recommended. What is the ideal one in practice according to you?
Sir, frankly speaking, in our rural setup, we do use a straight blade only. We do not have a video laryngoscope with us because it's a rural setup, and our experience with that is it's quite okay. We are managing starting from the newborn to all the age group.
I think the question is probably a Miller versus a Macintosh blade.
Probably it's like that, but there's mentioned it's a video laryngoscope, sir.
So that's the second part of the question, I think, if I read it that way. So the first part of the question is Miller versus Macintosh. Do you have any choice or any recommendation?
Yeah, since the epiglottis is little, it's not having a very good strength in the pediatric patients. So you can, it is always better to lift the epiglottis using the Miller's blade rather than using Macintosh in that cases.
Okay. Before you go on to the second part of the question, Mubarak, you wanted to add something. You said in your experience, Mubarak, you wanted to say something. Then Akshay will take the second part of the question.
Yeah, personally, I prefer the curved blade because I am more used to it. It is rather than the textbook description. It is the which one you are more experienced will be best for you. That's what I found. Then the second part of the question: what is your idea? What is the your opinion in using video scope like the AirTrack on infants?
So personally, we don't have any experience on the AirTrack on infants. We do not have that facility in us. And with this updating technology, definitely it has got advantage. So under complete vision, if you are intubating, definitely it has got some advantage.
Okay, I think if I may add on, Dr. Prema, the answer to the first question, straight blade versus a curved blade, I think one is, as Mubarak says, whatever you're used to is the best. Okay, don't use in a difficult situation, don't use an equipment that you're not familiar with. Having said that, when you use a straight blade, it is recommended that you lift the epiglottis directly. However, even completely trained pediatric anesthesiologists are now no longer directly lifting the epiglottis, and the reason is because we don't want any vagal stimulation. So I'm not sure, Prema, whether the question is answered. I would prefer, like Mubarak, most of us from the older generation are trained with the Macintosh blade, and we are quite comfortable using that. But even if you use the Miller blade, There'll be very few instances where you will directly lift the epiglottis with that. You can indirectly lift it by just, putting it in the valvula and lifting it up like you would a curved blade. And because of the connection to the epiglottis by the hyoepiglottic fold, the epiglottis does get lifted up. You can also use an external laryngeal manipulation. And in that context, Mubarak again explained that it is better that the laryngoscopist does the manipulation and a second person does the intubation. Because, in all earnest, when a second assistant applies the external laryngeal manipulation, they sometimes don't do it in the correct way. They don't push in the right direction, or they push it too much, occluding the larynx, especially in children, right? A very soft structure. So it's better that the laryngoscopist also does the external manipulation, gets the larynx into best possible view, and then the second person does the intubation. As far as video laryngoscopes is concerned, I think, in anybody's hands, intubation in small children with a small airway, the smaller the size of the glottis, is more difficult. And the same is true for video scopes like AirTrack also. Though it's a channeled laryngoscope, it will still be difficult for you to, pass an endotracheal tube using an AirTrack than it would be using a direct laryngoscope. Again, my opinion. I don't know whether Akshay would add on to that.
Sir, personally, I don't have experience on the AirTrack.
Fine. Right. I don't know whether Prema is happy with that answer. Otherwise, Prema can come on and clarify what he had in mind. Otherwise, we'll go on to the next question.
Yeah, we'll go to the next question.
Okay. Lakshmi says frequently this scenario is seen with video laryngoscope. Do you mean, Lakshmi, that your scenario of can see larynx and cannot intubate? Let's take it as that, Akshay. Lakshmi says you get the scenario of can see larynx but cannot intubate more with video laryngoscopes. I cannot more than agree with that.
Yeah, I too do not agree with that, sir. Our experience.
We have to agree, I think, because always video laryngoscope allows you to see the larynx, but the trick is how to get the tube into the larynx after that. For that, you need that coordination, the hand-eye coordination, which is more difficult. And unless you're more experienced, you won't be able to get that done.
So in that case, sir, the simulation lab will definitely help to train people.
Oh, yes. Right. Mubarak,
there is a question on the Celix maneuver, but would you like to add anything about the Akshaya, whether it is helpful or?
I don't know whether Akshay sees the questions. Can you read it out?
Yeah, sir. I can see a lot of questions are there.
Yeah, go ahead then. Go ahead.
Sir, actually nowadays it is a Celix maneuver is having a lot of controversies because of possibility of the gastric aspirations and the amount of the pressure it is being used. Practically speaking, they should be trained to use a particular newtons of the pressure has to be put. And for me, okay, we can go ahead with the Celix maneuver, but if you are unable to intubate back, because it has its own disadvantage. The moment you put more pressure, the vision is also again get affected. The glottis again, there will be compromise in the opening of the glottis. So you may not, that itself may act as a resistance to push the tube. So that time you have to release that pressure.
Okay.
Tushar, are you happy with that answer, or did you have something else on mind? Tushar, we'll wait for your response, Tushar. I will go on to the next question from Dr. Vigneshwaran. Can we take that, Akshay?
Yes, sir.
In Ludwig angina, that one?
Yes, sir. It was, see, when I practiced Ludwig angina during my PG time, all the time the oral surgeon used to ask us to intubate the patient. But at least at present in our rural setup, our oral surgeons are doing Ludwig angina without intubation. And we have done nearly in my 6 years of experience, we have done more than 100 cases with only IV sedations. So we keep a backup plan of intubation using fiber optic scope.
And there is a question on regarding edentulous patients, whether you would like to keep or remove the dentures. That's the question asked by Dr. Leo. Akshaya, doctor.
Sir, if it is for the mask ventilation, it is better to have it. For, I mean, actually speaking, if you are able to visualize the larynx, there is no point in keeping it. So
how much time do we have, Edward?
We have time, sir.
We have
That-
time, right? So I think, Dr. Vigneshwaran's question probably has raked up a bit of controversy in my mind, right? This is the Ludwig Sanjana question. A lot more questions there. So did you say, Akshay, that you would just give IV sedation and you have some experience in that without
yeah,
interfering?
sir. Yes, sir. Yes, sir.
And what is the kind of sedation you use?
Sir, we use ketamine. In titrated doses of ketamine, we use it.
Okay.
Keeping
I'm
a
afraid that
fiber
there
optic
may be,
pipe.
again, like somebody said earlier, there may be a lot of residents on this group.
Yes,
So I
sir.
think, this might be a risky answer in the examination.
Yes, sir.
And,
Yes, sir.
may cost you 6 months in the examination.
Yes.
So it's better to be safe, right? What you do after you qualify MD or DA is quite different. And,
Very true, sir.
there are different ways of skinning a rabbit. So, many million ways of doing it, but we have to be careful when we pass on information like this. This probably will need a bit more discussion. If time permits, we'll come to it at the end. But Mubarak, we can go on to the remaining. So many questions are there. Yeah, go ahead. Role of DLP, BURP in LCI. Okay. Now you're coining a new term, CalC. So it's already been adopted by Lakshmi.
So this
Role of
direct pressure-
DLP,
yeah,
direct laryngeal pressure, and BURP.
and BURP.
Yeah.
Sir, if it is applied in a proper way, it is good. If it is improperly applied, and this itself will act for the add-on for the calci. Okay, so the person who is visualizing the larynx, he should show to the person, or he should tell to the assistant that this much of pressure I need to visualize this larynx. So that much of pressure has to be applied by the assistant, so that the operator can easily intubate the patient. If the assistant is not good, as Mubarak sir said, all the key lies on the assistant, not the person who is intubating, frankly speaking.
Okay, I think for Lakshmi, if I may add on, we need to recollect Cook's modification of Cormack and Lehane view of the larynx. And it is said that when you get a grade 1 and 2A view, it's supposed to be an easy intubation. Most of us can intubate, whereas a 2B or a 3A will require some, I think that is where maybe some amount of, optimal external laryngeal manipulation, OELM or BURP may help. And once again, the person who's applying this additional maneuver must have an opportunity to look into the mouth so that they know what is the exact amount of pressure they are applying, and they are not doing it in the wrong fashion. As far as 3B and 4 is concerned, that is when we really need to sweat it out. Even external manipulations may not bring up a better view. I think it's good for us to look at this topic as three different. I think Cook's modification will help us to subdivide our patients that Akshay is talking about to 3 groups. 1 and 2A, most people can intubate. 2B and 3A, I think external manipulation, or like we say loosely, pressure over the neck may help. And 3B and 4, I don't think any of these maneuvers will help. That's kind of summarizes what I would have to say on that. Manisha Ghosh says, with video laryngoscopes, assistance is required with Bougie stillets. I didn't get the question. Could you figure it out, Akshay?
So I think she wants to use video laryngoscope, and that with that laryngoscope push the bougie or use stillet with tube.
It's an incomplete question as far as I'm concerned, but if you can answer that, that's fine. Yeah.
Sir, if at all somebody is able to see the glottic opening, a minimal opening, to push the tube or to push the bougie, that's okay, fine, it is acceptable. You can push the bougie under vision, even if you are able to visualize the partial amount of the glottis. Push under vision, and you can railroad the endotracheal tube. This is quite acceptable, no problem.
Okay. Go down. Intensive patient has already been taken care of. That question from Leo. Prema says, Ram, I'm not able to unmute. Okay, I think that's then the person who's Prema probably had a follow-up question on that. She's unable to unmute herself. Could somebody unmute Prema so that she can ask the question?
Usually,
just-
all will be muted, sir.
Yeah, all will be muted.
Okay, Prema, try again, please. Yeah, to unmute yourself. Okay, Tushar Choksi has an add-on. Shall I read it out? Akshay, did you know?
Yes,
Can you
sir.
scroll down and see Tushar Choksi? Please
Yes,
answer
sir.
that.
Yes, it is helpful for
For the
anterior-
others' benefit, we'll read it out. Yes, it is helpful in anterior or caudal larynx only. Message to our PG is that they don't do every time
time
Celix
Celix
maneuver and
maneuver.
every intubation. It is routine in some centers. So not Celix as a routine. That's what you're saying. Celix maneuver, I don't think should be misunderstood with external laryngeal manipulation.
True, sir. True, sir.
Right.
Yes,
Celix
sir, yes.
maneuver is specifically a maneuver.
Yes.
It's ideally done with one hand or a bimanual maneuver to occlude the esophagus to prevent passive regurgitation of gastric. Please don't use this term and mix it up with external laryngeal manipulation or backward, upward, and rightward pressure. So Tushar, please clarify that in your mind. Parthasarathy says the CALCI is about cannot intubate, not for vision of larynx. Okay.
He's suggesting. I think it's not a question.
Yeah.
People have misunderstood about the topic. Probably some of them. It's not about the visualizing the larynx. It's about the intubation after visualizing the larynx.
See, once again, going back to the basics, we know that the posterior commissure is wider than the anterior commissure. And whenever there's a problem, you're seeing the larynx, but you can't intubate. One, don't use any force, especially if you have a stellated tube in your hand. Any force can produce more trauma. And two, aim for the posterior commissure. You're more likely to be successful because that is where the space is available. Okay.
Sir, is there any possibility of this term CALCI to be introduced in any of the guidelines?
Who's asking that? Sudarshan,
Sudarshan? Yes.
No, I don't think. See, as it is, we are still struggling with so
Yeah.
many new terminologies.
Absolutely.
Okay.
Absolutely.
And
That's what
I think do we call it cannot intubate, cannot oxygenate? Do we call it front of neck access? Do we call it complete
Yeah.
ventilation failure?
Yeah.
Far too many terms already. And we have Nicholas Crimes talking about his what do you call that? Some particular principle he has. So there are too many terminologies going around already. CALCI will have to wait for its turn, I think, Akshay. Sorry.
Especially the airway assessment.
Much
Too
less of a
many things
problem.
are
You
there.
started off saying in your start of your lecture, it's much less of a problem. It's a question of only modifying your technique of passing the tube, so you're able to see the larynx, and that solves half the problem. So
Yeah.
the tricks are quite different in this situation, and it won't really replace any of the other terms which are not appropriate. Like as I mentioned, 3 terms: front of neck access, they cannot intubate, cannot ventilate, or CICV or CICO. And
Yes,
finally,
yeah.
what the All India Difficult Airway Association, of which I am a part of, has introduced what's called complete ventilation failure. So there are a lot of terms already, doing their rounds. I don't think CALCI should confuse it anymore.
With that, can we conclude?
I think so. Yeah, Edward, with the closing remarks from the moderators and the academic coordinator, we'll hand it over to Dr. Kumar back. Yeah, closing remarks, please.
Chairpersons, please. Closing remarks. Ram Kausar Bhupendra.
Okay. Closing remarks. Fine. Yeah, I think it's been almost close to 1.5 hours, and I think it's been a very informative and educative 1.5 hours. Thanks to both the speakers, Dr. Parthasarathy and Dr. Akshay. You have taken us through in a very simple manner without having too many complicating terms and complicating terminologies. I think it was very appropriate for a postgraduates or a postgraduate trainees group. Though I do see a lot of practitioners also in attendance. I think it was a very useful 2 sessions back to back. Thank you very much to the Tamil Nadu Association again, Tamil Nadu ISA. Please continue doing this. This is the need of the hour, and I think the residents will bless you immensely for all these efforts. As who was saying, Parthasarathy was saying that Edward is not doing any anesthetic practice now. He's only organizing webinars. I don't think that is true. It doesn't take that much of an effort to organize a webinar, but I think it's useful when you choose good topics, as has been done this time. These are my remarks, and thank you so much. Let's say goodbye and good day till we meet again next week.
Yeah.
Mubarak sir, your last word.
Thank you, the Tamil Nadu organizers, especially my classmate and colleague, Dr. Sudarshan, for organizing this wonderful webinar. Dr. Parsarthi as well as Dr. Akshay has taken us to the real scenarios and given a very good outlook of these two topics. And it was a wonderful session to share with Professor Ramkumar sir with these two sessions as the co-chairperson. So thank once again the Tamil Nadu ISA for giving me the chance. Thank you.
Thank you, sir.
Thank you.
We come to the end of the.
Sudarshan.
Yeah, yes, sir.
Just want to make one final remark.
Yes, sir.
We always refer to different algorithms or guidelines from different societies. Very often we tend to quote the American Society of Anesthesiologists and the Difficult Airway Society and so on and so forth. Just in case somebody in this group is not aware, in the year 2016, the All India Difficult Airway Association did bring out some guidelines. It is in volume 60 of the Indian Journal of Anesthesia. The then editor, Dr. Balabhaskar, was very kind to accommodate 5 guidelines all in one issue. So it's Indian Journal of Anesthesia, December 2016, volume 60. I think it's been a very concentrated effort of 1 year that took us to a 14-member committee, of which I was the chairman, to bring out these guidelines. We're hoping to bring out the new guidelines in 2021, 5 years down the line. And hopefully, if you can all read this and give your feedback, we may be able to incorporate some of those practical tips into the next guideline. Thank you so much. Yeah.
Thank you.
Thank you. Thank you, sir. Yes.
Thank you so much.
Come to the end of our today's academic event. So at this juncture, I thank Partha for her excellent information on the evolution of the inhalation agent. And also I thank Akshay sir for your eye-opening tips in the gray areas of the airway management. And I wholeheartedly thank the chairpersons, Professor Ramkumar Venkatesan sir and Mubarak sir, for spending their valuable time to enrich our knowledge. Thank you, sir. Thank you, Nanda. Over to Sudarshan sir.
Over to Kumar to hand it over to the next agenda.
Yeah, thank you, sir. We come to the end of this academic program. Thanks to Dr. Edwards, moderators and speakers for the excellent deliberation and a very good discussion beyond that. Now I invite Dr. P. Lenin, Treasurer ISA Thiruvarur for the branch report. Dr. Lenin, please.
Sir, good afternoon to all. Respected State President of Tamil Nadu.
Dr. Lenin, you are not audible.
Sir, hello. Sir,
Some more.
Louder, please. Louder.
Yeah, okay.
I am audible.
Yeah, okay, better.
Okay, sir. Good afternoon, sir. Good afternoon to all. Respected State President of Tamil Nadu ISA, Dr. Sudarshan, State Secretary, Dr. Kriba sir, and all other office bearers. I am presenting the branch report for our ISA Thiruvarur. Sir, this branch was first formed on 8th September 2017 by the great effort of our advisor of our branch, Professor A.L. Meenassundaram. At Kumbakonam, we conducted one CME on that day. On January 2018, we conducted a CME at Thanjavur, where all the national office bearers of ISA attended. On March, on the same year, on March, we conducted a airway management and for the paramedical personnel to help with the manicure, which was inaugurated by the then District Collector of Thiruvarur, Mr. Nirmal. On the same year, June, we conducted a simulation-based training at Thiruvarur Medical College for all practitioners and postgraduates. On the 19th January and September, we conducted a airway management program for local branch at Kumbakonam. At the Arasu Engineering College, our branch president, Professor Parsarthi, conducted an DLS course. Again, the government Women's College, Arts College at Kumbakonam, DLS course was conducted by our member, Dr. Balaganesh. Since due to this pandemic, our branch president, Professor Parsarthi, is conducting a webinar CME on every Friday. While starting our branch, we were around 25 members. Now we stood up to 35 members, sir. Thank you, sir.
Thank you, Dr. Lenin. Keep continue your good work at Tiruvarur.
Okay, sir.
Now I invite our ISA Tamil Nadu Treasurer, Dr. Ratnakumar, for delivering the vote of thanks. Ratnakumar, please.
Is he there around?
Ratnakumar?
Sir, I think
I don't see him.
Kumar is not there.
I don't see him. Kumar, you
Yeah.
Okay. Since Ratnakumar is not available, I'll proceed. I sincerely thank today's moderators, Professor Dr. Ramkumar Venkateswaran sir, Dr. Mubarak sir, for the excellent moderation and very good discussion beyond that. And Ramkumar sir has suggested that 2016 60th Journal of ISA about the guidelines. So I think everyone will look into that and will come with their views and opinions to support the 2021 new guidelines. Thank you, Ramkumar sir. Thank you, Mubarak sir. And I sincerely thank our today's speakers, Dr. Parthasarathi sir and Dr. Akshay. Like Parthasarathi sir, as usual, you did a fantastic job. You made the complex topic into a very simple one that definitely reached that postgraduates and all the delegates. Thank you very much, sir. And Akshay also, the way he presented that pictures, it is very useful for the postgraduates and the beginners. Thank you, Dr. Akshay, for the tricks and tips about that CalC. And I sincerely thank our academic coordinator, Dr. Edward. As usual, he did a fantastic job. He chosen the topics and moderators in a very cohesive manner. It was very good, well conducted. And thanks to all the delegates, all the members, all the senior members, national office bearers, state office bearers. Thanks everyone for attending and actively participating in this ISA webinar. Thanks everyone. And with this, we'll come to the end of this today's webinar. We have very interesting topics next week, which will be hosted by ISA Thindikkal. Once again, thanks everyone for the support and active participation, and hope to meet you all in next Sunday, 13th December at 11 a.m. Till then, bye for everyone. Take care and be safe. Have a great week ahead. Thank you very much.
Thank you very much. Thank you.
Thank you, sir.
Thank you, sir. Bye. Shilpa, you can close the meeting.
Okay. Thank you.
Thanks.
Yes. Thank you.
Thank you, Dr. Punaraj also.